Okay, a potpourri of information. I love that word. How are people with type 1 diabetes doing? And I want to frame this as saying sort of the around the globe ideas about research that's been good for people with diabetes, research that is making things better, and where we want to be someday, which is that best where there really is no diabetes. And I'm going to talk a little bit about all the different types of people and organizations around that are involved in trying to make things better by doing research around type 1 diabetes. And I'm going to start first to explain a little bit about the type 1 diabetes exchange. So this is a clinic network, more than 70 clinics around the United States, including both University of Washington and Children's Hospital in Seattle, that are caring for people with type 1 diabetes, had gotten together as a clinic network. Out of that network are more than 26,000 people living with type 1 diabetes who have agreed to have their information and data put together for people to learn. There's also an online patient portal called Glue that you can all go to and sign up and have conversations with other people and families living with diabetes. And there's also the Type 1 Diabetes Living Biobank, which we direct here at Benaroya Research Institute, and I'll tell you a little bit more about that. So the data I'm going to discuss right now is really about what have we learned a little bit about the 26,000 patient registry. So first I want to check, how many people here know that they're involved in the registries? Anybody? Fantastic. So now you can get some idea of some of the information. I want you to know there's more than 30 papers already published. It's a tremendous resource. So those of you that are participating, it's really, really helping us understand diabetes better. So I'm going to start first with a question about kids again. How many youth with type 1 diabetes meet the guidelines for glucose and blood pressure control? Well, first, I guess you got to know what the guidelines are. So up until 2014, if you were less than age 6, the goal was to be less than 8.5%. If you were a little older, it was less than 8%, and it was only when you were a teenager or above that the goal was to be less than 7.5%. Now that recommendation in the United States was actually different than the recommendations at other places in the world. So the International Society for Pediatric Diabetes has said for many years that the goal for all children should be less than 7.5%. But keeping those two pieces in mind, what's the data look like from the T1 exchange? Well, it turns out that 64% of kids under the age of 6 met the ADA guideline of having an A1C of less than 8.5. And about 40% of the younger kids, 6 to 13, and only about 20% of teenagers, which we all would expect, meet those goals. But what happens if we actually apply the more rigid criteria that the international group? And here we find that less than a third of people are meeting the guidelines. And these are now the new ADA guidelines as well. So about 27% across the age group are meeting the guidelines that we're really hoping people to achieve. How many hit the blood pressure target? Well, here, only 20% of people don't. Okay, so about 80% of people are getting their blood pressure checked and are getting appropriately treated for doing that. So what does this mean for you? Well, this is something I don't need to tell you, but living with type 1 diabetes is really hard. So some level it may be comforting to recognize that you're not alone if you're not making these targets. But that only tells us really we need the research to get better therapies to prevent this disease and cure the disease, because it's really hard to do. So other information, testing glucose matters. Now that's news to you, right? You guys had no idea, right? But I think, again, it's sometimes interesting to look at the data. And so I'm going to walk you through this slide a little bit. So what this is taking people, again, of the 26,000, people that are more than 50 years old, people that were very young, the 1 to 3-year-olds, the 26 to 50-year-olds, and the 13 to 26-year-olds. And no matter what age you were, how frequently you tested, so these are people that tested 13 times or more a day, their A1Cs were better, right? And if you only tested less than 2 times per day, unfortunately, those are the people whose A1Cs weren't as good. What about news about kidney disease? Okay, steps towards kidney disease, and Earl alluded to this a little bit. We think about the progression of kidney disease as you start out with kidney's doing fine with no protein leaking in the urine. The next step is to have microalbuminuria, which means a little bit is in the urine. Then it goes to macroalbuminuria, where there's a lot of protein in the urine, and that can lead to the kidney problems or kidney failure, as Earl mentioned a little bit earlier. Oh my goodness. Okay, so what new information? Well, Dr. Palmer is going to speak to us after lunch a little bit about the advances from the Diabetes Control and Complications trial after 30 years. He's not going to speak about kidney disease, so I thought I'd grab this bit of interesting information. So it turns out that of the people that have been treated for more than 20 years with diabetes, 94% of the people who had good glucose control and 83% of the people that did not start out with a good glucose control did not have macroalbuminuria. Okay, so the good news is that overall, most people, even after 20 years of diabetes, didn't have any problems with lots of protein in the urine. Nonetheless, there's a difference between 94% and 83%. Again, better glucose control, less likely to have macroalbuminuria. But what happens if you actually get macroalbuminuria? Well, of the people who did get macroalbuminuria, remember it's a small number, treatment still means better results now. So let's say you start here, and let's say you've had all that protein in the urine for 10 years. Remember, I previously told you that means you're going to get kidney failure, right? This new data is much more encouraging. 2/3 of the people did not get kidney failure. So even with 10 years of macroalbuminuria, only 1/3 of the people will actually progress to needing dialysis or transplant. So I thought that was good news. What does this research mean to you? Well, this is what I was saying at the beginning is good, right? Improved glucose control and new treatments is really making it different for how people are doing with their diabetes. Okay, many people with type 1 diabetes still are making at least a little bit of insulin many, many years after diagnosis, particularly if you were diagnosed with type 1 diabetes as an adult. So I'm going to show you data from the study we did with the Type 1 Diabetes Exchange. Now, again, many of you probably might have come in and actually had your insulin secretion measured. How many people did that as part of the exchange study? Okay, thank you again for doing that. So here's what we learned from that. This was in color. I don't know why it's not. Okay, so if you were diagnosed under 18 years of age, so that's the dark bars here, and you've lived with diabetes for 3 to 5 years, about half will still have insulin secretion that we can measure. 6 to 9 years later, it's almost 30%. But even many years later, 7 to 8% of people who are diagnosed as children, we can still detect a little bit of insulin secretion. And you'll hear from Dr. Atkinson later how we can look at that in the pancreas samples of people who have died from diabetes. What about if you were diagnosed as an adult? Here's the lighter bars. 85% of people, 3 to 5 years from their diagnosis, are still making insulin. By 6 to 9 years, it's almost 70%. And if you continue to look out with the duration of the disease, people who have lived with diabetes more than 40 years, who are diagnosed as an adult, about 10%, we can still see that there's insulin secretion being made. So what does that mean to you? Well, the more insulin-producing cells that you keep after diagnosis, the better you do. The less complications, the less hypoglycemia, the better it is just to manage disease. But what I've just shown you is what we would call the natural history. It's just measuring what's going on and telling you, and that's kind of good news because most of us have always said, no, you're going to lose all your insulin secretion and it's going to happen very fast. That's not true. But what we really want to do is intervene in this process. We don't want to just keep watching it. We want to see if we can preserve the insulin-producing cells. And the good news is that there have been lots of clinical research studies, and there's now 3 therapies that were shown in those to have kind of this story. So this story here is we measure insulin production, we enroll people in a clinical study at the time they're diagnosed with diabetes, we give some people the treatment, and some people get the placebo. It's not the people I like or don't like, right? It's a randomized process. Some people get active drug and some don't. And you can see that the people who receive the active drug have more insulin production. Initially, the studies are reported at 1 year and then 2 years. And as we continue to follow people, there continues to be a benefit of some of these interventions. Now, you've already heard a little bit from Dr. Hagopian earlier today, but here's my cartoon of the natural history of the disease. We know you start out in life at some point with all of your insulin-producing cells working fine, but over time, that destruction keeps wiping out the cells, and at some point, you get clinical onset of the disease. After diagnosis, you often go through the honeymoon period, and even though this graph still shows it going to 0, as I just explained, for many people, that never gets to 0. Okay, we do know, and again, you got introduced to this concept already, that prior to the onset of clinical diabetes, we can find this process beginning, and we find it by measuring antibodies. And you've already heard now from several speakers, so I'm going to say it again, because you all get this message. You have 2 antibodies, that means diabetes has started. Diabetes does not start when your blood sugar is high. Diabetes starts when you have 2 antibodies. Because everybody, as far as we understand now, who has 2 antibodies seems to eventually be going on to get diabetes. So that's really exciting news in the sense we know this now. We have that information, but it's sort of not very exciting news unless we can change the course of that, right? That's really where we're going here. And so the idea here is this is where we were doing the graph I just showed you, where we're trying to prolong the honeymoon. We're treating people at the time of diagnosis to save the remaining insulin-producing cells. And the idea here now is we want to do it back here. Among the people that have antibodies, so we know they're going to go on and get disease, can we stop it? Or can we slow it down? That's where we are now. And the way we do that is through a different organization, not the T1 Exchange. This is now Diabetes TrialNet. It's NIH, that means your tax dollars, and JDRF funded network. It's an international network, which is why the globe's here, aimed to preventing type 1 diabetes. So who is at risk for getting diabetes? It's relatives. Relatives of people who have diabetes are the ones that are at most risk, and those are the people we screen to look for the presence of antibodies. If we had 300 people who had no family members with diabetes, about 1 will get type 1 diabetes. So that's the incidence of diabetes in North America. If we had 300 people who had a family member with diabetes, about 15 will go on to get diabetes, 15 times more. So relatives are 15 times more likely to get diabetes. Now, many of you are sitting in, well, everybody in this audience has someone in your family with diabetes. And you're saying, hey, I already know about diabetes. I don't need to screen. I'll know if my brother's getting diabetes, their blood sugars are higher, they'll have symptoms. I've seen them. It's not going to be new to me anymore. But you know what? That's too late, right? Diabetes starts when you have antibodies, not when your blood sugars start high. And we know that if people have antibodies and we follow over time, their blood sugars will start rising long before you have symptoms of having your blood sugars being high. Okay, we can only detect those rising by doing these studies on a regular basis. If you wait until you're symptomatic, you've already way past the point that we want to stop this disease. And you've heard from several speakers already today. By doing that, we actually follow people and people don't get sick. They don't have to be hospitalized at the time they're being diagnosed. So you need to detect this before any symptoms happen. So how do you do it? Well, there's only a couple of steps. Step 1, get tested. Get tested to see if you're eligible to be in a prevention study. You could do that today at our booth out here. Step 2, if you're eligible, enroll in those studies. We have 3 studies ongoing now that are really trying to see, can we stop this darn disease? So what does this research mean to you? Well, this is the best, right? Good, better, best. The best is no more type 1 diabetes. On the other hand, those of you sitting in this audience are saying, hey, but I'm living with diabetes. What does this have to do with me? And the point here is that prevention leads to cure. So you may have heard in the news, it was very splashy, I must have got 1 billion emails, right, that there's an investigator in New England who's found a way to grow these nice insulin-producing cells that are glucose responsive. That's terrific. And once we can do that, or we can regenerate your beta cells that are sitting there, we still have to stop the immune system from destroying them, or they're just going to be destroyed again. So prevention studies really help everybody with type 1 diabetes. Now, the other piece I mentioned about the T1 exchange, I talked to you about diabetes TrialNet. At Benaroya Research Institution, we study a lot about type 1 diabetes, but we also study other autoimmune diseases because the causes and mechanisms that underlie type 1 diabetes, rheumatoid arthritis, multiple sclerosis are very similar. So the idea at BRI is that we're trying to understand what the causes, the genes, what are the mechanisms, so that we could turn to our pharmaceutical partners and say, okay, we think this is a pathway that you need to develop a drug about. This is the basic science that underlies all the research that goes forward. So we have what's known as the bridge study, BRI, diabetes study, very clever, right? So it's bridging this science with clinical medicine. It's getting blood samples from people like you so that we can better understand this disease. So what does this research mean to you? Fundamentally, understanding the mechanisms and the causes of the disease is what gets you to good, to better, and to best. Bring it on, it's our new slogan. Obviously, I didn't come up with that one, that we hired somebody to come up with it. But the idea there is, really, there's lots of autoimmune diseases. We want to tackle them together. But let me ask you a question. How many of you have participated or a family member in diabetes research? Oh, wow. Am I speaking to the choir here or what? This is fantastic. So thank you. Thank you for doing that. For those of you who have already participated and those who have not yet decided to participate, really it's participation that accelerates diabetes research. You can do it through TrialNet to prevent diabetes if your relative has diabetes. Anywhere in the world. We're headquarters now for Diabetes TrialNet here at BRI, okay? But this is a worldwide effort, okay? Diabetes and the Immune Tolerance Network, we have hot news here. We're starting some new studies, again, for people that are recently diagnosed with getting diabetes. So if people have been diagnosed in the last month or so between the ages of 12 and 45, we're going to be starting some new studies for new therapies. That's our hot news. But some of you in the audience may say, hey, my relatives have already been tested, or I don't have any relatives, or I'm not newly diagnosed, so how can I participate? And it turns out there's new news also with the Type 1 Diabetes Exchange. Hot news. I love doing that little doodah in my PowerPoint, okay? In the past, the T1D Exchange participants in the Living Biobank are only the 26,000 people or so that were part of the original registry. But actually, just starting this week, we are now opening that to anybody who is living with Type 1 diabetes. Some of you might have asked if they could participate in the bridge study at BRI in the past, and we said, you know, we're really focused on those first several years from diagnosis, and we can't really use you. I'm telling you, we want everybody now. Okay, if you have type 1 diabetes, or you know somebody who has type 1 diabetes, we'd like you to start up and sign up for the Living Biobank. Now, what the heck does Living Biobank mean? All it means is we have your name, you've given us permission, and I talked to a scientist who says, I want to understand how this gene affects some immune system. We'll call you up and say, hey, could you go in next week and get your blood drawn? We need a blood sample. Okay, that's what a living biobank is. It means we're not wasting your money to take all the samples and just put them in the freezer. We're getting them from you when you need it. Okay, we're kind of like Amazon, right? Okay, so you may be thinking you want to help, but you're confused. I've already gone through a whole bunch of logos. It's keeping you from lunch. Maybe you even think I'm already in studies. Is there more you could do, and how would you find out? We're trying to make it easy for you. A single spot information center. If you stop by our booth, the Benaroya Research Institute today, I'm making all my staff work on Saturday, and we're there to let you know what you and your family can participate in, okay? We aim to be your Amazon for type 1 diabetes research, so you don't have to kind of say, should I do this or should I not? Just come ask us, and we'll let you know what you could be eligible for doing. So thank you very much for your attention.